I don't see that any of the hospital even thinking that a patient who is suffering with chronic debilitating condition or a patient who is suffering with some kind of a serious health related disorders should be treated differently. He has a right that if end is inevitable, he has a right that end should be dignified, and we have to make the policies and protocols for such kind of a patient. We all know that in the medical science there are the time comes when we just doctors just cannot do to prolong life, and when life cannot be prolonged, we have to take care of the patient till the time patient is there without extending life in the ICU or with the vasopressors or all sorts of medical or technological advancement. So I don't think that this is existing, and I will give you the magnitude and the huge problem all over the world. The way we are taking, we are giving the backseat of the most important aspect of medical science, which is end of life care. How a person can end their life when end is inevitable with a dignified way. So the next, I can't change my slides. Can you remove the screen from the side, Dr. Abarma? There are so many screens are coming out in the side, so that I cannot go to the. Can you remove the side screen, please? All chat box and everything is opened in the side screen.
Ma'am, it's in your it's on your side only. You don't have control on that. You have to press.
Okay.
Ma'am, what you can do is just click anywhere inside this window of your PowerPoint presentation, and then press F5.
Slideshow, please.
Okay,
slideshow.
So, this is because slideshow screen is not coming
No,
in
it's
front of
yeah,
me.
it's right there on the right side, down,
This
right
is
bottom.
everything is controlled
Next
with
one,
the
next one,
cover. Yeah, everything
next
is
one,
covered with
next
the
one,
slide.
next one, next on the right.
At the bottom right, ma'am.
Right bottom, just close to the volume, or close to that.
Yeah.
Yes,
So,
that's it.
so sorry. So now, first of all, we should what is the magnitude of the problem? Why we are discussing, and why I'm saying that we have just neglected the most important aspect. So this is the photograph, and this is the slide, which says this is the report of 2015, and now 2020 reports is also coming. And in this report, they have analyzed the quality of death index in 85 countries, and what we can see that India is almost in the bottom line, almost on the 67th position as far as the quality of death is concerned. So this means that India has become one of the worst place to die. Why this has happened? Why we are lagging behind? And the best place where the quality of death index is best was in UK, and almost the best places 8.5% of the countries where the quality of death was good, or we can say the best, they have an integrated palliative care or end of life care program in their continuum of care of their patients, those who are suffering, whether they are suffering with any of the illness, but it was there in their continuum of the program. This means their undergraduate doctors, postgraduate doctors, their nursing staff, everyone was learning how end should be dignified when end is inevitable. So this is a report from 2004 to 2016, which was published in Public Health Journal, England, from the England. And what we can see that a patient, almost the hospital admission in the patients from 2004 to 2016, the deaths in the hospital are decreasing constantly, and patients those who are dying at home is increasing almost 5.1%, and in the hospice 0.9%. Means there is, because of the integration of end of life care, or because of the integration of continuum of care, palliative care in continuum of care, their medical system has improved, and the people, they are spending their most of the time either in the hospice or at home, but they are not dying. It's like, it is not that all patients are dying in the home or hospice, but at least it is in the decreasing trend. Similarly, when we see the global atlas of palliative care and end of life care, you can see that we just, whenever we talk about palliative care and end of life care, we just only discuss the cancer patients. But it is not only the cancer patients, there are multiple other diseases, patients suffering with chronic congestive heart failure, patients suffering with chronic or interstitial lung disease, patients suffering with intractable multi-drug resistant tuberculosis, and so on and so forth, multiple sclerosis. There are n number of neurological disorders where we think that, oh my god, this patient is unnecessarily suffering, but we keep treating that patient inside the ICU with all sorts of vasopressors. So this is just, this picture is an alarming, this slide, and this says that all these patients, they need some kind of palliative care and end of life care. Now the global atlas of 2020, which has been released in last 2 weeks, says that almost in the world, it is not, I have not brought any Indian figure, but in the world 56.8 million people are estimated people, they require palliative or end of life care, but only 12% need is met. Means only 12% patients, those who need end of life care, and those who really, where the death or end is inevitable, they are getting dignified end. So it is a alarming figure, and we should do something. And I am very happy again that this hospital, this organization is doing in this direction. Basically, how we can do this, because now talking to this is different, but how can we do this? So we have to consider, and we have to make the policy that if a patient is in the hospital, if he is going and he is going to die, it is going to be part of his journey. So right from the diagnostic to therapeutic strategies, there will be a time come when the patient is going to die. For example, a patient who has been diagnosed recently, now the curative treatment is more. As the disease will progress, the palliative care take the lead. So palliative care concept should start from the beginning, so that patients should get holistic care from the beginning. Patient has got a lot of problems, psychological, social, emotional, all these should be addressed from the beginning. As the disease will progress, when the patient will go, the palliative care take the lead, or when the patient is going to die, that time the end of life care concept should come, and it should be dignified end. So ultimately, whenever a disease is the whole in the disease spectrum, end should be part of our medical curriculum. And without understanding and that it is part of our should be part of our medical curriculum, I think our medical science remains incomplete. If we don't treat our end also as a part of our teaching, as a part of our training, that this should be dignified, I think our teaching and training is incomplete. So what should be the key component of end of life care? Ultimately, what exactly we have to do? We have to give honest information. We have to give patients realistic hope. When end is inevitable, we have to explain to the patients and their loved ones, and we have to give the hope we don't have to destroy, but we have to give this hope to realistic hope. And ultimately, when patient is going to die, he is going to suffer with all sorts of suffering with the symptoms. So ultimately, aim should be that we are not going to desert this patient. Something policy we will make that patient, we will take care of pain and suffering. We will control the patient's life, and we will say that patient should be in control of his life to maximum possible. And when control is not possible, we will give maximum dignity to the patient and respect at every level. When patient is in the early stage of the disease or at the end stage of the disease, respect at every level, and proper documentation. Whatever you're talking to the patient, you are explaining the disease prognosis, you are explaining the end of life care, you are explaining that there is no need to go to the ICU or futile care. Everything should be documented. And all these things should have been done by empathy. Nobody needs sympathy. There is no word in sympathy. I think sympathy does not work as far as my experience is concerned, and otherwise also. Always patient needs empathy, and almost everyone, if I ask these audience, everyone wants to end their life with the loved one, but this does not happen. Most of the time we spend our life either in the hospital or in the ICU. So AIMS has started end of life care policy. Almost 3 or 4 years we have worked, and with this policy, AIMS has taken AIMS has taken that the all the patients, those who are registered, we are going to provide the dignified end to the patient. And the purpose of this policy, that end of life care, is to minimize symptoms and give the pain-free dying process at the terminal stage when patient is suffering with chronic debilitating condition. This is the procedure of AIMS end of life care policy, that we will recognize dying as a normal process. Once we have recognized that this patient is not going to make it, it's not going to survive, everyone will sit together. We are going to give with the primary physician or palliative care physician, whosoever is involved in the team, we are going to give honest, accurate, and early disclosure of prognosis to family by proper communication. And this communication should be amongst the physicians, amongst the nursing staff, those who are available in the ward, and the patient and family members. So all these people together, everyone should be on the same page. And once the consensus amongst all the caregivers will be there, we will, whatever consensus has been reached, we will have a transparent and accountability through the documentation. Everything we will document that we have set together with the primary physician, family members, and all the nursing staff, whosoever is available. We will document that we have explained the futility of care, and we have explained the we have given the prognosis to the patient, and patient and their relative, they have understood the care plan, and we will make the goals of care to the patient. And once the goals of care is is there, we will start our institutional supportive care plan will be started. And in the supportive care plan, as we have explained to the patient, that we are not going to do something to prolong the life, but patient is suffering. If patient has got any symptoms, we will treat the symptoms. If patient has pain, we will treat the pain. If patient has breathlessness, we will treat the breathlessness. And ultimate aim will remain that we are neither going to hasten death, means we will not do something to hasten death, means we are not pro euthanasia, but we will not postpone death by putting the patient in ICU, or by putting the patients on vasopressors, on dialysis, or something like this. But we will definitely take care of the symptoms if patient is suffering with the intractable symptoms. Uh, the key of success in my experience in the AIMS was the teaching and training of nursing staff and our residents, because most of the time 24 hours nurses are there with the patients, and residents are also most of the time are looking after the patient. So once we have started teaching and training resident doctors and nurses, almost all our nurses in the hospital, whole of the AIMS, we have given end of life care training program through the LNIC program, which is an American certified course for nurses. We have trained our nurses, and once all the nurses were trained, they knew that this patient's end is near. They discussed with the primary physician. They remain in the same page. They also understand that what doctors is teaching And when we will discuss with on the rounds or with the primary physician, they keep on giving emphasis to the same communication to the relatives, and relatives ultimately understand. So the key of success of our program was teaching and training of nurses and doctors. And because of this, what I have found, I have brought a very initial figure that from 2018 and 2019, when we used to go for end of life care consultation, it was 18%, and it has increased in till July 2020, it has increased to 31%. So imagine a patient who is suffering with terminal illness, a patient who is suffering with chronic debilitating conditions. At least till July 2020, we were able to provide to 31% patients end of life care. And this is my last slide, that this we have created system for us. We are not obliging anyone. This system is for ultimately for us. Tomorrow, if I will be suffering with some kind of a debilitating condition or some kind of a illness where my cure is not possible, my resident doctors and my treating doctors, they have taken the oath that if cure is not possible, they will care me, they will care for me, they will give me the symptom management, and they will allow me to die with my family members, but they will not put me in ICU with all sorts of tubes and ventilators. Otherwise, all heads, all VIPs, all MPs, all MLAs, all ministers, they are spending their end in the ICU away from loved ones. So this is what should not happen, and we have to create the system. Otherwise, we all will die in ICU, which we never want. We all want that ultimate desire of ours will that we should be ending our lives in the with our loved ones. And because our doctors are trained in end of life care, because our doctors are trained in palliative care, and what I have realized that COVID care in NCI Jajjar, because they are trained, they have a concept of palliative medicine. Most of our patients, they are getting benefited because they already have a concept of. So critical care and ICU, which doctors are looking after those who are trained in palliative care, they are giving this benefit to our patients even in the COVID care. Thank you very much. And I am again saying that I am really grateful that this is initiated by this research foundation. Dr. Shakti, I'm really, really grateful that you have taken the initiative, and those who are listening, almost 120 people are listening. They will try to make the difference. They will try to make the policies in their hospital. And I think it will be a huge benefit to the patients all over the country. Thank you very much.
Welcome.
Thank you, ma'am. Thank you for this very nice introduction, and also giving us the overview of the problem and what it entails. I will now request our second aspect of end of life care that we are going to cover is the clinical aspects, and I will request Dr. Gayatri Palad to cover this for us.
While we are waiting for the presentation to be opened, I really want to congratulate the entire team led by Dr. Gupta and supported by Dr. Verma and other senior faculty. It's a great opportunity, like Dr. Sushma said, that we're speaking to a group of people who are going to make that decision in the hospital, that how a patient who is dying need to be cared. You are the people who are most critical, because otherwise many times we struggle to make that change in the hospital. I'm so glad today we have around 126 experts joining, and we are discussing this such important subject. Thank you very much for giving me this opportunity. Great. So I'll be requesting Dr. Verma to help me with the change of slide.
Yes, ma'am.
Sorry about that. Yeah. So Dr. Sushma gave a very nice framework about how we are going to take forward this discussion with the various other speakers and experts. So I thought I'll start my presentation with actually sharing a story of a patient. Now, this story will very much reflect with the framework which Dr. Sushma created and in line with the kind of outline she gave. Here is a story of a gentleman, 68-year-old male with advanced cancer lung. He was brought to the hospital with a history of severe breathlessness. Because he was breathless, as a hospital protocol, the physician decided to shift him to ICU. Next. Yeah, because he was very restless, they had to physically restrain him. They tied him down because he was so restless on his bed, and they had to really tie him down. Soon, arterial saturation began to fall. The resident decided to put him on artificial ventilation. 2 days later, he passed away. This is the story of a patient, CA advanced cancer, and came with a history of very severe dyspnea to the hospital, became very delirious, admitted to ICU, restrained because he was so agitated, put on ventilation, artificial ventilation, and he died. It was obvious to the doctor that he was likely to die because he was having advanced cancer and he was not doing well. It was not obvious to the family because he had been in and out of the hospital so many times in the past. So they thought one more of those admissions. And when he died, the family was very angry. Do you relate with this situation? Dr. Verma, can I just say, when I say to move, then only we'll move the slide, otherwise it's very confusing. Yeah, thank you. Sorry about that. Yeah. So do you relate to this situation? I'm sure many of you connect with this because we keep hearing, so the conflicts which we hear so much of these days by public versus hospital, how the public gets very angry and often they beat the doctor and they bring down the hospital. Often this conflict arises because the expectation of the family and the patient and so the hospital the people who are treating the patient. Where the things went wrong, according to him, according to you? A patient, advanced cancer, bad symptoms, he was brought to the hospital, he was put on a ventilator. Why do you think, what went wrong here? Okay, let's look at some thoughts which I thought I will share. You can also chat if you think you want to share something parallelly. Next slide. Next slide. Yeah. So look at some of the things which I thought, which came to my mind, I prepared. He had obviously very poorly controlled symptoms. He was suffering, and that's the reason he was brought to the hospital, even though it's such an advanced cancer. He had such bad dyspnea, and he was delirious. Was there a rationale for putting a mechanical ventilation on such an advanced cancer patient? What is the justification of doing that? Are there enough evidence to say that these patients get benefited by this? How was his death? His death happening in isolation, no family member around. Remember Dr. Sushma's slide, the last slide, but here it was totally the opposite. He was all alone in the hospital, died in isolation, no preparation. Were the family even prepared? We don't know yet. No family preparation. And it's not a very dignified kind of death. That very profound picture Dr. Sushma shared, the last slide, if you look at it, when you say dignified death, what is the dignity? Your no tubes down your throat or all the possible orifices in your body, away from your family, in lot of suffering. Everything is what we call it is against the dignity. What about patients' emotional needs? Were they addressed? How about family who are waiting outside? What was happening to them? So all of these questions, these are all questionable. What happened to this patient and his family? Next slide. Next, yeah. If you, many of us, we think that when the patients have such severe symptom, when we ship them to ICU, things are taken care of, and that's the reason we often ship them. But I've just taken some studies which are not Indian studies. I've taken studies from one of the best centers in the world, and they looked at how well the symptoms are managed in ICUs. If you look at this study, which says that 55 or 75% of ICU patients with cancer experience pain, confusion, anxiety, sleep disorders, unsatisfied hunger, and thirst. Next. There's another study which states 20% of patients in MICU did not receive treatment for pain or dyspnea. Even though we think the ICU, everything is taken care of, 20% of patients in MICU did not receive treatment. And when patients were delirious, restraints were used more often in ICUs. And which is, again, when you talk about dignity, this is definitely not a nice way to die. When you're tied down to the bed and and even for the loved one to see their loved ones being tied down like that. So this is what is happening. This is what the study says, that the symptoms are often suboptimally managed in ICU. Next slide. Family, we often don't even remember what the family is undergoing outside. Families often hear very conflicting views from physicians, the different doctors who come on duties, and often these conflicting viewpoints or even their own expectation and confusion leads to a lot of confusion, anger, hostility, and frustration. Next slide. Globally, these days, people are talking about patient-centric care. There is a seismic shift from the traditional way of looking at care to the patient-centric care. And if you look at the core element of patient-centric care, it's all about respect for patient's preference, integration and coordination of care, information and education to the patient and the family, physical comfort, emotional comfort, involvement of patients and family, transition of care and access to care. So when you talk about even end of life care, these things apply. So when we talk about patient-centered care, are we really applying this to our patients who are dying? Next slide. Next slide.
Yes, it takes a while for you to see the change in your screen.
So I just thought, okay, when you what you suppose we have the best of facility in your hospital and you are dealing with this same patient once again, same patient, 68 years, advanced cancer lung, is coming to your hospital. What is the best we could have done for this patient, considering when we talk about patient-centric care and having a proper policy in place in your hospital? Probably what I would do, I would say that what is best for this patient is, most important, establishing what is the goal of care for this patient at this point of time. And this we can establish only when we have a very fair, open, honest communication with the family and the patient, if the patient is in a capacity to make decisions. And the decisions are what we call it as shared decision making, understanding what is happening. And based on that, making an advanced care planning as to what the patient wants in terms of his care, and very much taking into consideration his values, wishes, and preferences. Dr. Sushma mentioned about symptom management, how like they aggressively they look at symptom management in the hospital. So for this patient also, if you really want to give a good end of life care, I would look at impassable assessment and management of symptoms. Crisis plan. If you look around in most of the emergency services, when you emergency services in the hospital, almost 50% of patients who are coming to emergencies, surprisingly, they are all with chronic illnesses with acute on chronic some kind of crisis. They must be having some underlying problems. So for example, end stage kidney diseases and the patient reporting to the casualty with severe dyspnea. So all this results because very poor crisis plan is made. And it's not a surprise when you have such kind of advanced end stage conditions, they develop crisis. But we fail to make any crisis plan and the patients land up being in the hospital, or sometimes they die on the way trying to move from one hospital to another hospital. So coming back to this patient, if I have the choice, I will make that goal of care getting established. I would like to have a good symptom management for this patient. I would make a crisis plan so that even when there's crisis happening, he knows where to go and where to get that support. And of course, planning an end of life care for this patient because he is nearing his end of life. What is the plan we have and where are we going to provide this end of life care? Is it going to be in his home or in the hospital? If it is in the hospital, where he's going to get it? Next slide. When you talk about symptom management, there are enough tools available to make what kind of assessment we need to make for this kind of patients. All kind of symptoms they may have: delirium, dyspnea, vomiting, headache, pain. So there's enough scales, validated scales, enough studies done on these scales. We can use those assessment tools to make assessment, and based on assessment to provide care to such patients. There are enough protocols and guidelines available. One such simple guideline is what is introduced by the World Health Organization for the management of chronic persistent pain. So cancer pain, chronic persistent pain, this is a very beautiful guideline as to how to manage pain. The point is that how we implement and how to use this in our day-to-day practice when we're dealing with such patients. Next slide. So put it all together, coming back to same gentleman, having advanced disease, coming to the hospital. I see around 122 participants here. Most of you are working in different hospitals in various capacities, and I'm sure almost all of you, you're seeing patients. You may come, you're going to deal with patients who may die in your hospital. So if you want to care for those patients in your hospital, the World Health Organization says you need to have the 3 areas in your planning. One is, do you have a policy to take care of such patients? Dr. Sushma showed how, when you have a policy in place and it's implemented well, how you can bring such a beautiful change in the shift in how such patients are taken care of. If you don't have the policy, then it doesn't work. So do you have that policy in your hospital if tomorrow this patient comes to your hospital? Second is drug availability. These patients, very often they need very special medicines. These are not expensive, very simple medications like opioid medications, like morphine, simple oral morphine. Do you have such medications in your hospital? Because that is a very core component of providing palliative care. Do you have such medicines? If not, how do we work around getting the license to get those medicines in your hospital? So you have to think about that. And the third component of the triangle, suppose this patient comes to your hospital, is your team competent to provide such care? What kind of training your staff is having? What kind of training your intensivist is having, or the doctors who are dealing with such patients and stage conditions? Do they have such kind of training? Doctors, nurses, all health workers, and the policymakers. So when you address all the 3 elements of this triangle, I think you can provide such a good care, good end of life care to these patients. With that note, I stop here and we take the discussion forward with other speakers. Thank you.
Thank you, ma'am. Thank you for this presenting the clinical side of the story. And our third aspect of the end of life care is about the ethical dilemmas, ethics, and communication. So I'll request Dr. Mani to cover this aspect for us. With his huge experience, I'm sure we will get enlightened in this session. So, Dr. Mani, please.
Am I able to share?
Just a moment, sir. I'm making you presenter.
I'll just. So we have set the tone wonderfully with Dr. Sushma and Dr. Gayatri's presentations to take this forward. How do I? Okay, now let me start with thanking Dr. Shakti Gupta and Dr. Rakesh Verma and the Research Foundation for this wonderful opportunity to address you all and to share, some insights which we learned on the subject. You see, it's extremely important for ethical basis to be there for our medical practice. This we all know, but however, we've been lagging behind the rest of the world. In 2003, I published an article on the ethics and legality of limitation of the support in the ICU in the Indian Journal of Critical Care Medicine in 2003. In 2005, the Indian Society of Critical Care Medicine published the first guidelines on end-of-life care, and subsequently 2012 and 2014, along with Indian Association of Palliative Care. So you see, what we need to talk about ethics before law, because we have been overly sort of obsessed about the legal side and for self-protection. But before everything comes, the relationship, the doctor-patient relationship, and what are the ethics governing this relationship? See, you see the iceberg at the, sorry. So the iceberg at the bottom, is the values, is a societal values, is the moral value basis. From moral values come principles, and they then reflect in the practices. So we have new ethical dilemmas. As we progressed in medicine, advances of medicine in the 50s and 60s brought about new ethical dilemmas. So what were they? We had a problem of a twofold death, a circulatory or brain death as the starting point, and then one could keep a patient alive even with not a great prognosis or even with imminent death for a prolonged period of time, maintaining the physiology. In the 1970s and 80s, there was a lot of awareness of the ethical dilemmas in critical illness and life support. And this is a seminal work by Beauchamp and Childress in 1979, which is the basis of how we practice critical care today, or life support and issues around life support. So they formulated the basic tenets of modern bioethics. They are the fourfold principlistic approach, that is autonomy, beneficence, non-maleficence, and justice. How have they come? They've come out of a collective sense of morality. There are some are called normative moralities, which are not variable across cultures, across continents. Not to kill and to tell the truth, for instance, are these normative moralities, and not to cause harm, and to work for the benefit of those people with whom you have a relationship, particularly in medicine. See, the fiduciary relationship is what we have. It's not just a judicial relationship. It's not a contractual relationship. It is a fiduciary. That is, for a father and son, or two siblings, or two people who are related. So that kind of relationship of trust that happens. So these are governed. The relationship is governed by these four principles. So let us see how this impacts on end-of-life care and limitation of life support concepts. So, lot has been spoken about autonomy. What is autonomy? Originally the doctor-patient relationship was a very lopsided one. Okay? It is a paternalistic physician-patient relationship where the physician decides and the patient complies. And this gave way to a more equal relationship, in modern times. It's given way, particularly in the 70s and 80s, to a more equal relationship, and that has happened to our country also. What does autonomy mean? Autonomy means that the person has a right over the bodily integrity and how how to control what is done to the body. So you may lose control as you lose consciousness, but that right, basic right of control over yourself, your personhood. It's not just physical personhood. It's also your values, your ideas of life, and what you value, your priorities. Okay, the person, larger person, apart from the physical person. So there is a right of free choice. Now, the autonomy concept has been very weak in the Indian environment, although we recognize it willy-nilly by having to take a consent for every procedure. However, as in itself, strengthening autonomy was done only recently by the common cause judgment. But it's been there in the world for a long time. The Patient Determination Act established it in 1991 in the US. So the right of free choice and the right of refusal of what one does not want, an unwanted treatment or a treatment that for due to one's values you don't accept, even if it is to the detriment of refusal, those things are now established in the world, and they are increasingly getting recognized and accepted in our midst, and has been constitutionally validated by the common cause judgment. So the right of refusal, as I said, is the basis of refusing life support. And withholding is to refuse the initiation of that life support, and withdrawal is refusal of continuation of the life support once it is started. The second one is beneficence. Of course, the doctor-patient relationship is based on uh, physician intending overall well-being of the patient. This is a very basic tenet. It cannot be compromised for anything. So there is an essential duty of care to act for the benefit of the patient, but this benefit scope has been expanded to not just include physical, but also the whole person of the patient. That is the values and wishes and priorities. And that is why goal setting, as mentioned by Dr. Pallad, goal setting is so important to extract or elicit from the patient. What are the values and priorities? And those things must guide our treatment policies. To empower the patient to exercise one's autonomy and judgment is also part of beneficence. That is why truth-telling, openness, open discussion is very important while the patient is competent, and if the patient not competent, the surrogate or the appointed person, legally appointed proxy, should have the empowerment. As it often happens, there is none of these four principles are complete in themselves, nor does one prioritize over the other according to Beauchamp and Chinese. When there's tension between the two, the benefits must outweigh the harms. So this tension often happens with the principle of non-maleficence, which is exemplified by the phrase primum non nocere. So harms of treatment are there for every single treatment, potential harm. But then they should be reasonable, and the harms should not outweigh the benefits. And the harms are also in terms of expressed values and harm to the family. For instance, if you prescribe treatments that the family can't afford, or they go into bankruptcy, that's also to be included. This should be incorporated in the judgment of how you discuss and arrive at a policy. So a physician is really obliged to prevent harm, to do no harm, to remove harm, and to promote good. So these are the things about non-maleficence. Social justice is the fourth one, which is really to have a fair sort of approach to the patient, be non-discriminatory in every sense. And also when there is a pandemic in our midst, for instance, when you need to ration resources have to be used very intelligently and efficiently. And if you have to do that, then you can't be using futile treatments, which will really erode this principle of justice. Even if you have to ration, it has to be done in a transparent and fair process. So there is a problem of dignity in death, which is mentioned by Dr. Sushmaji, and then showed in that vivid image in the end, how heartrending it can be when there's a deprivation of dignity and personhood at the end of life, and not being in the midst of the loved one. So it is a physician duty to consider when not to do too much, when not to do disproportionate treatment. Now, we have increasingly come to recognize through research in the recent times that disproportionate treatments are very common. It ranges from 22 to 30% of patients in the ICU, in many point prevalence studies in Europe. So disproportionate treatment harms the patient by prolonging death. It certainly flies in the face of bioethical principles and causes great economic and emotional distress to the family, and to the caregiver it causes moral distress, compassion fatigue, and leaving work. What are these terms? Moral distress is your fundamental beliefs of how you must conduct yourself with the patient as a physician and a human being. If you are doing something different from that belief, it causes moral distress. What is compassion fatigue? Okay, we talked about empathy. Now, empathy is getting into the shoes of the person you're treating and understanding what the person is going through. Compassion is feeling for the person and acting through that feeling. That is compassion, to reduce the suffering. So if you are doing that and you are not able to have the ethical environment in which to function, in which to implement these compassionate deeds, then you go into compassion fatigue and you get frustrated and there is work attrition. So ethical environment is now defined by many studies. It is really awareness of ethics, which is reflecting in policies as per the AIMS policy now, which is reflecting in the policy of the institution. In every institution that I have worked, I have implemented end-of-life care policy according to the ISCCR guidelines of 2005 and later of 2012 and 2014. So not avoiding ethical dilemma. When you take, Dr. Gayatri Pallad showed you the case, when you take a very easy course out and a very, you think legally correct course and self-protective course, then you do not have a resolution of ethical dilemmas in medicine. So end-of-life decision making is one such big ethical dilemma which you must confront and resolve. So that is the ethical environment. Now, a collaborative decision making, a collegiate decision making with other colleagues across multiple disciplines, including nursing and social worker and psychologists, is the sort of decision making that is nurtured in an ethical environment. And then the leadership is self-reflective, self-reflective and responsible leadership, which takes charge of such patients and takes leadership for these decisions and implementation. So I want to conclude by saying that education and training ethical practice is greatly needed, and you could see how wonderfully it's being implemented in the premier institution of the country, in All India Institute. And this is our experience too, that we train through an ethical culture, ethical environment in the unit, everybody, from the junior most physician to the leader and all the nursing staff and even the support staff. So a physician-patient relation, which is a fiduciary one, it should be rooted in ethical principles. We must integrate all the four principles as far as possible in our decision making. One or the other may predominate for the individualized patient. A lot of patients do not want great autonomy. Many patients want a lot of autonomy. So we have to come somewhere in between and produce a very personalized and effective end-of-life care, rooted in ethical principles. Thank you.
Thank you, sir. Thank you very much for this, for sharing the ethical aspects of the end-of-life care. And I think this is one such situation or scenario where the ethical clarity is possibly the most desired, and also it should guide all the decisions that are taken. So we are now coming to the legal quality and the accreditation perspectives of the end-of-life care, and I'll request Dr. Siddharth Satpathy to cover this aspect of end-of-life care.
Sure.
Thank you.
Thank you very much for inviting me, and I've heard the other three, speakers, and they have actually made my job much easier. I have just a few slides so that we can have the online session and the national grand rounds more interactive, because I believe a large number of 112 is being shown, so a large number of people are participating. So it would be good if we could have a more of an interactive sort of thing here. Now I have been given the responsibility of sharing my views and perspectives on three areas, that is quality, accreditation, and the legal perspective. Dr. Mani just now has finished the ethical perspective, and I thank him. He made a wonderful presentation. I will go into a relatively more difficult and uncharted territory, as it were, because most doctors are bad lawyers. They are not lawyers as such, but they are not able to many times hold their case in the courts of law. Can I have the first slide, please? Yeah.
It's on, sir.
Okay, the next one. So what I will do is I have actually flipped my presentation. So I will be discussing more about quality and accreditation initially in the first 4 or 5 minutes. And then I will go into the legal paradigm because that is a little more complex and complicated as well. I'm sure most of the delegates are aware that in April 2020, the NABH has unveiled the 5th edition of the NABH standards. These are the standards which are in vogue in India today. These are homegrown standards which were started about 1.5 decades back in the year 2005. And the current edition of the standards have actually, classified the standards into 3 categories. The first category are the core, standards, which are the objective elements. The core objective elements, which are 102 in number, out of 651 objective elements. And these are assessed at all times. All assessments, these are being assessed. 459 assessments are commitment assessments. That commitment objectives. That is, the hospital or the healthcare organization leadership and the clinical team has to show commitment towards these objective elements. In the third category, we have achievement category. This is about 60 throughout the entire standards, 651. The achievement category will be checked during surveillance visits, and it will also be checked during the final assessments. And the last category are the excellence. These are 30 in number. Now, if we go to the standards as such, although most of the standards worldwide, whether it is JCI or the ACHS or the HQS or the Thai standards, which were the most recent in the Asian continent, most of the standards have some or the other elements regarding end of life care. Unfortunately, till about the 4th edition, this was not there in the NABH standards. There were only few objective elements which were depicting the end of life care part. Now in this, the care of patients 20th standard in the 2nd chapter is basically dealing with the end of life care, and I will read out what is there said in the slides and then try to explain. So it says end of life care is provided in a compassionate and considerate manner. Most of the previous speakers have already discussed about this. The best thumb rule to remember would be to put yourself in the patient's shoes so that you are able to know what he or she is feeling about the care that is being received by him or her. And each of the objective elements, say first is, it is said that it has to be done in a consistent manner throughout the organization. Now, if we see this, national grand round, we find that there are 3, clinicians here, and out of 3 clinicians, 2 of them are dealing with cancers. So when the standards say consistent manner, it is not referring to only those patients who are, receiving terminal care, who are cancer patients. It is also applicable to a large number of other non-cancer patients who are also in a terminal stage for whatever disease that they are suffering. So the first is consistency. That means it has to be there equally across the length and breadth of the hospital. The second issue is it must be provided by a multi-professional team. And here it becomes getting a little more complicated. Many times the multi-professional teams are not available in a large number of hospitals, which precludes providing, proper care in the proper professional manner. The multi-professional team could include the, treating physician under whom the patient is admitted, some other, clinical disciplines who have provided consultations. Because it is a fact of life that many patients nowadays have comorbidities. So even though the primary physician would be one, there may be many secondary physicians, and sometimes the orders that are given and the drugs that are provided to the patients are working at cross purposes. So being in sync with the primary physician and preparing a multi-professional team will be the role of the hospital administrator. The third is a minefield, and about this I will discuss subsequently in the second part. It should be in sync with legal requirements. I must, congratulate and put on record my sincere thanks to Dr. Mani for that, for their, activism, and like the Crusaders, they have led and got an order out of the Supreme Court. But then the war is not yet finished, and that I will tell in the subsequent part. So it should be in sync with legal requirements. This is a relatively complex thing which we will discuss subsequently. The fourth issue which it says it identifies unique needs of patients and families. This again is a very difficult area. Identifying unique needs of a terminal patient is okay. When it says identifying unique needs of patients and family, that makes it a little more complicated. And we will see in a small case which I have made for you, which happened at AIIMS. Am I audible? There seems to be some background noise. Dr. Rakesh, am I audible? Dr. Rakesh, am I audible?
Yes, sir, you are audible.
Yes, sir.
Okay, fine. So the fourth thing was identifying unique needs of patients and family. I will discuss in a subsequent case. And last is symptomatic treatment and pain relief. Dr. Shushma and Dr. Gayatri Palat have very clearly and very lucidly have explained. Many times at the point of death or just before that, pain, especially in cancer patients, seems to be the predominant symptom. But there are other symptoms also. And if pain is managed well, I believe that we are in the path to the, to a dignified death. Can I have the next slide, please? Next slide, Dr. Rakesh.
It's done, sir.
Okay.
It's there, sir.
Now, I think in my device, it is showing the same one. So
on
has
the
it
screen,
changed? Yeah, okay. Now it has come. Now it has come. Now this slide is a repetition of what Dr. Shushma showed you. And it is right, it is correct that India is ranked 67 out of 80 countries. We have progressed. There is no doubt about that. The earlier ranking, we were ranked 40 out of 40 countries. Now we are 67 out of 80, and probably, we are taking baby steps in the correct direction. Can I have the next slide, please? Now you see, this is probably my last slide. And this slide, I will try to unravel for the listeners the legal landscape in India. It is commonly said that if you are not aware of the law and you make a mistake, you will be penalized for that, right? The legal landscape in India is very, very complex. Somewhere I had read that we have something like 28,000 laws in the country, and about 3,000 of the archaic laws have so far been, sort of junked or sent to the dustbin. But still, we have a large number of laws, and the most important laws, when we see it from a doctor's perspective, would probably be the Consumer Protection Act, and also from the criminal, jurisprudence point of view, it would be the Indian Penal Code. So when we look at quality versus quantity of laws, we have a large number, and I'm sure none of the lawyers in the country, even the best practicing lawyers, remember all these laws. So quantity is there, but quality of the laws remains pretty bad. In the sense, they are quite convoluted. They are very, very complex. and many times not only the laws but also the adjunct rules and regulations are not clearly decipherable or understandable by a common man, and the result of that is fear. When somebody is not understanding a certain thing properly, it is but natural that the fear would be there, especially if you are an ethical person. You would have the fear of stepping on the wrong side of the law while you are practicing in your profession. Few years back when I was trying to find out about the legal definition of next of kin, amongst the various laws, I was surprised to find that next of kin has not been very clearly defined in a legal term, in a legal sense, in any act. Now, what happens is whenever the interpretation of a certain thing, a statement or a concept, is within the executive territory, it generally depends on how the executive is interpreting that part. The moment it leaves the executive domain and goes into the domain of judiciary, then things start getting more and more complex and people start going deeper and deeper into it. I will say this, that, when the Right to Information Act was passed in 2005, we took a conscious decision at AIMS that whenever some person is asking for the patient care records, if the patient himself or herself is asking, we will provide it. If any other third person is asking for such records, we will not provide it because that is categorized as third party information as per the RTI. Then what happened? We faced a problem when the patient died and the relatives or the family members of the patients started asking for records. And then it was decided as per the decision which was taken by the competent authority, that in case of death of a patient, we will provide it to the spouse, number one. Number two, it will be provided to parents or children. And in the third stage, we will provide it to siblings. Now, that is the standard reply that we are providing in the RTI replies when somebody is asking for patient-related information of a patient who is no more. If we look at the judgments that have been given by the various courts at different points in time, again, there doesn't seem to be any consistency and any progress in one direction. Now, there are cases where, I will just try to tell you about two important things in the, Indian Penal Code, which is actually causing the maximum amount of fear in the minds of the, the clinicians and the physicians. And these are section 309 and 306 of the Indian Penal Code. Now, 309 of the Indian Penal Code says attempt to suicide is a penal offense. There is a penalty can be given for that. And 306 is abetment of suicide. So if we see, the judgments given by the Bombay High Court and in P. Ratinam versus Union of India case, where section 309 was, discussed threadbare, and the courts held that attempt to suicide should not be considered, as a penal offense. And the matter, in another case, that is Gyan Kaur versus State of Punjab, where abetment of suicide can also be penalized. This was then challenged because the argument that was put forth by the lawyers was that since in the previous case, section 309 has been invalidated, so 306 becomes automatically invalid. But the courts, many times, give decisions which are progressive in nature, but they are not able to give the exact, the implementation part, and they leave that generally to the executive, that is the governments, and to the institutions. So, in the very famous case of Common Cause versus Union of India, Dr. Mani was also a part of that, and Common Cause took up the case. This is a corollary of the Aruna Shanbag case, a very famous case, which had shook the conscience of the nation. In this case, the common cause versus Union of India, the court tried to answer basically two questions. The first question that it tried to answer was that whether the right to life also has the right to death of a person or not. And what the court said was that if a person is having is compos mentis, that means is able to take decisions with a free will, then in that case, the person can give what is called an advance directive, and that directive must be honored, right? The second thing that they basically laid down in this part was that an adult human being having the mental capacity to take an informed decision has the right to refuse medical treatment, including withdrawal from life-saving devices. But they stopped there and they did not spell out or did not give any policy directives to the executive, because that is also another issue, that many times the executive sees such type of progressive decisions as judicial activism, and the executive is not willing to sort of take these things. So that is the end point where advance directives have been allowed as a part of the court judgment. And section 142 of the article 142 of the constitution allows the courts to give such type of directives to the executive, but then that is the end point. So far I think the executive has not yet enacted any law on this particular matter. And I don't know, I mean, if in the future some law gets enacted on end of life care, that will make things a little more easier for the people, because the interpretation will not be that much varied. Next 2-3 minutes, I will just tell an interesting case study which happened at All India Institute. About 3 years back, what happened was there was this old gentleman who got admitted into the private ward. So far, so good. He was a chronic kidney patient and he got admitted under Dr. Bhaumik, who was a nephrologist, and in the private ward. Now, in the existing system that we have at All India Institute of Medical Sciences, and now every patient, when he gets admitted, one of the family members or the patient himself or herself has to sign the generic consent and a specific consent in case any surgical procedures are done. Now, this generic patient, because this patient was elderly, having chronic kidney disease and admitted in the private ward, it was signed by his son. So far, so good. And then this patient remained in the hospital for about 17 days, if I remember correctly. And on the last day or few days before that, he was shifted to the ICU, and then he finally died. Well, I mean, there are patients who, come chronic kidney disease, advanced age, 70 plus. It is possible that death would be there. We were surprised to get an RTI query from one of the sons of this patient, who asked certain very, very, peculiar questions. And he asked questions as to, when was my father admitted? And he gave proof that he was his son. He was probably the second son. And he asked as to when his father got admitted, who was the treating consultant under whom his father had been admitted. And then he asked who all were there with my father when he got admitted. And the fourth question was still more interesting. He said that on 2 days before his death, on so and so date, who all were the people who entered the room of my father? Did any judicial magistrate enter the room of my father while he was admitted at All India Institute in room number, I think 309 was the room or something like that. And then he asked that how much time did this person stay there, and who all were present, were the nurses present or not. So when we were these sort of questions about which no information was available, I went through the case report, the case file, because the patient was dead. So I called for the case file and I couldn't get any answers on these questions. Then, since we could not, reply properly, suddenly this gentleman, he made a call. And then I came to know that there were 4 children that this person had. And the third son had got his father admitted. And 2 days before his death, because he was aware of what was going to happen, he changed the will of his father in the hospital. And just after that, probably the patient was shifted to the ICU, and 2 days after that, he died. And the other sons have now all ganged up against son number 3, and the whole matter is in a mess, and it is in the court. So this is, the legal minefield that I was, talking to you about. That while this is definitely a progressive step, and this is definitely the need for the day, and given the constraints that we face, but the challenges could be very, very, crucial, could be very challenging, and we have to actually think about all circumstances when we are moving forward with the end of life care. So the way forward, I request Rakesh to show the last slide. As many of the my earlier speakers have all said, this is a documentary, I think 58 or 55 minutes, about euthanasia in Netherlands. This patient was having terminal disease and was having physical pain plus mental agony and the depression and all those things, and he opted for passive euthanasia and finally died. So this is a moving film about what his last thoughts few days before his death were, and how the family members faced the bereavement. So ultimately, what we are looking at through the end of life care is a dignified death, but we will have to cross the legal minefield, and I hope that soon enough we have a proper law on this, so that we are able to chart out a proper course. Thank you very much.
Thank you very much, sir.
Thank you, Rakesh.
It was a presentation that covered many varied sides of this complex care requirement, the stage of end of life. Having completed today's topics, the session is now open for everyone to ask questions. The manner will be that you could ask the question on the chat box, or you could unmute your mic and ask the questions. We will have a time of maybe about 25 minutes or 20 minutes maybe, and this can be used for asking questions. Okay, I think the first question has come in the chat box. Raj has asked, is end of life care same as DNR? What is the legal status of end of life care? I mean, there are two ways of approaching this. One is that I request a particular faculty member to speak about it, or if you can take the question on your own.
Rakesh, you see, I think I will give the hospital administration perspective, and then maybe the clinicians can add on to that. DNR, DNR or do not resuscitate. You see, we will have to see as to who is saying about DNR. Now, what the court judgment has clearly said, that if there is a patient who is compos mentis, that means this person is capable of taking, decisions, correct decisions. In such a case, if this person is saying that, do not resuscitate me as and when I have these problems, I am aware that I am suffering from so and so disease. I am aware that this is a terminal disease, and this is my wish, right? In such a case, a DNR order or a DNR request coming from a patient who is compos mentis must be implemented by the clinical team, because the Supreme Court has allowed this to happen. And we must not forget that if any family member is not happy with this DNR thing, the only way the family member can do something is to go to the court, or to the Delhi Medical Council if it is in Delhi, or to the Medical Council of India, or NMC if the matter is somewhere outside Delhi. The person can go to a court of law. And in a court of law, an order given by the Supreme Court, a constitutional bench of Supreme Court, headed by Justice Deepak Mishra with 5 justices sitting, cannot be taken lightly. So if the person is having compos mentis, that means is of sound mind, and such a patient has given it in writing, and there are one or two people who have been witness to this, I believe the clinical team can go ahead and do it. I can ask them. We can take their opinion as well.
You see, I must express a few things. If Rakesh, can I have a word?
Yes,
Sure,
please.
Hello?
sure.
Yes, sir.
So you see, Dr. Sushma Bhatnagar and I were a part of the ICMR task force to create the DNAR policy. Firstly, let me explain what DNAR is. Do not allow resuscitation. This does not include withdrawal and withholding decisions of life support. Okay? It
Yes,
is only whether you want to do CPR or you don't want to do CPR. And
absolutely.
CPR is defined as a medical procedure. Now, any medical procedure like surgical procedure, it is the decision of the medical body of people to prescribe or not to prescribe. Let us understand that one thing. So I would refer everybody to this ICMR document, which was published in March this year. No, maybe, yeah, on DNAR policy. Now, we
Okay.
don't have to quote for this. Now, I must say what Common Cause judgment said. See, active and passive euthanasia, we must understand again very
Yeah.
clearly. Active
Absolutely.
euthanasia
Yes.
is you are actually injecting a lethal drug, okay, at the request of the patient and voluntary request, and these are governed by various laws in Netherlands and other things. Now, what we are talking about is a so-called withdrawal withholding, which is loosely called passive euthanasia. That is allowed by the Common Cause judgment. In
Yes, it is
principle,
allowed.
withdrawal withholding is allowed, advance will is allowed. Now, in implementation, they give a three-tier process, okay, by which the judicial magistrate of the first class is involved. A local, what do you call, board is there. Then the judicial magistrate of first class is there. Then there is the local district collector. Now, this process is not in place. We have checked in various places. The
Right.
process recommended by the Supreme Court is not there yet. Now, there is another route, because we have worked with legal bodies, especially the National School of Law in Bangalore and Vidhi Institute of Legal Policy in Delhi, that there is this common law. The common law is a process which does not need legislation. There is
Okay.
already a route of refusal of treatment. And if the patient himself cannot do, himself or herself, now 95% of patients in the ICU who are on life support cannot be compos mentis, right? That we know, that is the data. So those people who are not compos mentis, you have to sit with the proxies and do it. And in any case,
Absolutely.
advance will is also recognized. Now, what I want to say is this is a subject which has renewed itself very rapidly in the last few years. Much has been written on it by myself also and by task forces. You must look at the FICCI illicit document also, okay, which outlines how this is done. Now, in the absence of the Supreme Court giving a procedure, a statutory body like ICMR, okay, is something we can follow, or the professional guidelines which are in place. Now there are so many professional guidelines. There's All India Institute is there. There's ISCCM guidelines, IAPC guidelines. There are this Kasturba Medical College and Manipal Hospital guidelines of Blue Maple, and there are international guidelines. So it will make it very complicated to go through the court and all that. We cannot decide because these decisions have to be taken within a few days or even a few hours. So this is a subject in itself, of course. And please, I refer to these papers, which you can go through. They're all in the public domain.
So, Dr. Rakesh Solanki, I think that answers your question. Is DNR legal in India? Shashikant Sharma has a comment and a question. What I know is DNR is not legal in India. What should a doctor do if he or she encounters a tattoo on a patient's chest? Do not resuscitate. Dr. Mani,
See,
sir.
DNR is legal. As I told you, DNR is legal by the Common Cause judgment and by ICMR guidelines. If there is a tattoo across the chest, ethical rules and ethical understanding behooves us to take that as the wish of the patient. Why would we ignore
Absolutely.
everything is not
Absolutely.
legal? The whole thing is grounded in ethics and humanity and compassion. And why would you override that on the basis of our understanding of law? The thing is, law
Absolutely.
has to be ethics. Yeah. Law
I,
cannot
I
go
am totally in agreement. Yeah, I agree with what Dr. Mani has said. Absolutely.
HP has asked, is euthanasia legal in India? I think this question has been answered. Raj has another question.
active euthanasia not legal, passive euthanasia legal.
Yeah, active is not legal. That's right.
Raj has asked, say a patient is not in a condition to consent. So then what?
For what? No, not in a consent. This is a very half-baked question, I guess. Not in a position to consent for what?
So, Raj, you will have to reframe our question. Marshal, Dr. Pawan Kapoor has a comment. End of life care is not the same as DNR. DNR is a component of end of life care which can be exercised based upon the existing regulatory requirements. I think your comment is well taken, sir. JS Murli has asked, can a hospital refuse admission on the basis of uncertainty related to end of life care? Dr. Siddharth sir, will you take this answer?
No, what is the question? Can you repeat the question once again?
Can a hospital refuse admission on the basis of uncertainty related to end of life care?
No, then you'll have to define what uncertainty is there. You see, if he is talking about a patient who has come to the emergency, we are not talking about end of life care when a patient is reaching the emergency. So, one has to be a little more specific about what sort of thing. The general ground rule is, if a hospital is not equipped to handle the type of patient who has come, the hospital is well within the rights to say no.
I think, J.S. Murli, that covers your question. If something more is required, please specify. Rajhans has asked, is there
Can I comment?
Yes,
ma'am.
Dr. Shushma.
Can I comment in this, that whether a hospital can refuse? I don't think that if a patient is coming in the hospital with some kind of a symptom and refusal or not refusal, I think it does not come into the place. In the emergency of AIM, our palliative medicine residents, they are posted. We are sending many patients at home, but it is not that we are sending at the straight away. Once patient is there, we keep the patient for few hours. We try to explain to the patient, and most of the time, cancer patients, they have already been explained long time before. But if patient has not been explained, we explain to the patient about the futility of care. We give them the
Absolutely.
symptom
Absolutely.
management, and then we ask them that we give them an option, that there is an option of taking care of this patient at home. There is an option of taking care of this patient at hospice. And what is the disadvantage of keeping these patients in the hospital? And
Perfect.
most of the patients, if you explain well, they could try and they opt to go home. So rather than refusing and not refusing, I think communication is the most important. That I don't think that a patient who is suffering with any kind of a symptom, we can refuse to the patient in the terminal stage. We have to explain to the patient, give them the symptom management, and then send them home. And most of the patients, they are going home, and they are, there is no problem at all in this. There is no problem.
Okay, thank you, ma'am. Rajhans has asked, is there a time limit of validity of DNR given by compos mentis patients? So if a patient has specified, is there a time limit?
Can I come in? It can be changed anytime. A
Yes.
compos mentis patient can change the decision anytime. Even if the patient loses consciousness, the decision on behalf of him is taken by physicians and the proxies. They can
Yes.
always revisit and redefine
Absolutely.
decisions. Yeah.
Rakesh, I'll take the analogy of will here. Let us look at will, advanced will, and when we are looking it through the lens of end of life care, let us look it as a will, right? Just as a compos mentis, person or a mentally sound, competent person can change his or her will till the time that the person is compos mentis. The same holds true for the this advanced directive and the living will. That is why it's called a living will.
Thank you, sir. Dr. K. Satyanand has asked, many a time very terminally ill patients, prognosis is very bad, very unlikely to improve. But if the relatives insist on ventilator support and aggressive management, especially in a government institute, what should be done?
I think Dr. Shushma can take this question.
So Pam has explained, but
So again, yeah. I have explained it in my lecture, but again I can explain you again that it is not that if a patient or their relatives is asking for aggressive management, we are going to refuse. But again, there's a role of communication comes. We cannot
Absolutely.
refuse when patient is gasping, and you have not explained it before. But many a times patient will come to the emergency. This happens in AIMS that patient has and their relatives have already been explained, and they come to the emergency. They say that we just want pain management, we just want that
Yes.
she should not be
Yes.
breathless, and we don't want intubation and ventilation. So this has
Absolutely.
because long time before we have started explaining. So again, if relative, I told you one step in end of life care policy teams that everyone should be on the same page. Consensus amongst all the caregivers, including primary caregiver, primary physician, palliative care physician, nursing staff, as well as family members and patients. If they are not on the same page, we have to continue the treatment till the time we are able to explain them the futility of the care. Once the futility of care is explained, if patients if they understand, then we can take another step by proper documentation.
Right.
Thank you, ma'am.
Perfect.
Is it clear?
Can I add?
Yes, ma'am.
Hello, can I
Yes.
point? Yeah. So I want to go back to the very basic question which was raised. The question about is DNR and end of life care, are they just the same? First of all, what do you mean by end of life care? So end of life care, end of life care means, when do you say it's end of life care? Is it last day, last 24 hours, last 1 week, last 1 month? So that's something we have to define. What do you mean by end of life care? Yeah, when you say end of life care, it is the word itself. Care means it's about patient care, and it encompasses a very big spectrum, starting from, like I said, symptom control, planning, advanced care planning, in which comes the advanced care directive, where we brings the DNR part of it. So advanced care planning is a big spectrum, under which it comes the advanced care directive, and then also planning the crisis plan and where the patient is going to die. So all this comes under end of life care. It's not just one element that DNR is end of life care. They say that the statistics says that 10% of death happens suddenly. Roughly 90% of death happens following a prolonged chronic illness. People live for a period of time, they decline in their condition, and they die. Why is it that these patients are always coming in crisis with no plan whatsoever, and then they die? Don't you realize beforehand, when the patient's condition is declining, that this patient is not going to make it? I think this patient is not going to live long. So can't we have a planning, end of life care planning, much ahead, much before, so that we don't get into this crisis of patients suddenly landing in casualty with some crisis, and then that point of time trying to tell the family and having this discussion that leads to a lot of emotions, flaring of emotions and conflict. So I think with this kind of awareness classes and more awareness among health professionals, we should target at addressing this issue much ahead, when the time a patient is diagnosed to have a chronic progressive disease. We should start having this kind of discussion. Thank you.
Right.
Dr. Anand Singh has asked a question about the end of life care where the patient is not able to pay for the care that he is going to get in the hospital. So, Dr. Anand, I think this is a question that is not directly and specifically related to the topic of the day. But your comment that is it a loss to the hospital? Well, I think we are getting into a domain which is outside the purview of today's discussion.
Absolutely.
Dr. Rajaji Pillai is wanting to have the copy of the end of life care policy of AIMS. I think this policy is, ma'am, available on the AIMS website.
Yes, it is.
Yeah, it is available on the AIMS website. Yeah, it is
Dr.
available.
Balaji, you can take from there. A few more comments.
Okay,
about,
sir.
few more comments about the tattoo on the patient's chest. Well, one such comment is that the tattoo may have been made by someone else. So,
Rakesh, I want to make one
Here,
small comment.
I want to say, sorry, Dr. Mani, continue.
Sorry. You
About
know,
the
this
tattoo, I wanted to answer.
not being able to pay and producing end of life care, that is nonsense. You know, that is not ethically well grounded. See, not being able to pay is not a trigger for end of life care, not at all. Only the patient condition, prognosis, and so on, whether their ability
very true,
to
sir.
pay or not is separate from that. Now, if they are not able to pay, you have to relocate the patient appropriately. That's our responsibility. They pay. So to a hospital, to a government hospital, or a lesser expense. Yeah.
Dr.
Or
Shukla,
if
you saying?
possible. Yeah.
Ma'am, mute. Ma'am, you need to unmute. Dr. Shukla, ma'am, we can't hear you. You have to unmute. Yes, ma'am, it looks fine now.
So I just wanted to say that tattoo, who has made this should not be the question. A doctor will have to act in the best interest of the patient. If
Correct.
in the best interest of the patient, if treatment is going to be the best for the patient, I think we have to continue. Or if patient has already wished that do not resuscitate, and we know that it is a reversible condition and patient can make it and patient can survive for a long time, I think we should continue the treatment. But if we think that it is not going to be futile, we should honor this tattoo and continue this do not resuscitation.
Thank you, ma'am. Dr. Rajeshri has commented that passive euthanasia is a misnomer. I think, Dr. Rajeshri, you may like to go through the Supreme Court judgment on this. There is sufficient clarity there. Dr. Mani has also explained this. Dr. Rakesh Solanki has said many times attenders don't want to continue treatment because of financial reason. I think Dr. Mani covered this aspect. So we can leave it at that. And okay, there are more questions on withdrawing or withholding life supportive measures in terminally ill patients. Dr. Mani has referred to us on the guideline that is there, the ICMR guideline. I think that should cover this aspect. We should access that.
There are the ISCCM guideline, 3 of them in the main space. There's a India Institute guideline. And there is a FICCI illicit guideline and ICMR guide. All these are there in this space.
And as far as I know, all these are available. All these are freely available in the public domain, so they can be accessed easily.
Available.
Yes. I think there are no more questions. So thank you, sirs, and madam, thank you very much. We had a good discussion on the subject, and I think we need to close now. It's close to 5. In the end, I would like to thank all the participants for participating in this program actively. And finally, this program has been possible only because of the motivation and the force behind the program, and was Dr. Shakti Kumar Gupta. Without his guidance and his motivation, this program would not have been possible. So we are indebted to him for having inspired us to take this step forward. I'm also thankful to very senior professionals and very senior doctors in the forum today. Air Marshal Pavan Kapoor is here, and there are many others. Dr. Shakti himself is here. Thank you very much, sir. And thank you very much for adding value to the program today.
Rakesh, one thing, I'm Sergeant Captain Somit Roy from Bombay, if you remember me. Will it be recorded in our RFHA, this thing? Because in the National Law School, where we have pursued this medical legal ethics, we want to share this with the fruitful discussion.
No, sir. What is your question, sir?
Question is whether it will be shared in our portal of our membership. We have got the membership of your RFHA.
Sir, the recording of this session will be available on the YouTube channel of the Research Foundation, so it will be uploaded maybe in a day's time.
Okay, thank you so much.
Thank you.
Thank you, everyone, sir. Thank you very much. Thank you for participating. We will have another similar session on a different topic next month. So that, of course, will be made known to everyone. Thank you very much. Thank you.
Thank you. Thank you so much.
Thank you.
Thank you, Dr. Rakesh, and thank you, Dr. Shakti Gupta. And I am liking one very important take-home message from Dr. Preetam Bora. Communication, counseling, and discussion with relatives is very important part of end of life. I think he has understood everything very well.
Absolutely.
Thank you very much.
Thank you. Thank you.
Thank you all the participants, sir. It's very informative. We really learn a lot. We are looking forward each and every Saturday at this state time. Thank you, sir.
Thank you.
Okay, Rakesh, it went all well. Thank you very much.
Thank you very much, sir. Thank you, sir. The video and the audio connected well, sir.
Okay. So I'll have to buy something which is non-Mac for GoToMeeting, I guess. Okay. Take care. Bye. Thank you.
Thank you very much, sir. Thank you, sir.
Rakesh, well done, actually. So we had a nice actually interaction, and everybody should be looking forward for every Saturday meeting. That Saturday, actually, the same base plus the monthly actually grand round on their diverse topic. Even the participant who participated, they can suggest the topic also.
That's right. That's right. We can.
So we have taken suggestions earlier also.
Suggest some. Yeah.
Sir, there is a list of close to 100 topics already in the waiting, sir.
Oh my God. So 100 weeks are gone. 100 months. So we will surely come out of COVID by that time.
There is nothing to worry. Actually, every Saturday we block actually for coming 1 year. Actually, what topic you are going to have.
Right, yes, sir. Right, sir.
So I think it will be a very good idea. We also invite one senior professional in this every Saturday.
Okay.
We have participation of close to 100 people almost every Saturday, sir. Almost 100 people every Saturday.
Okay. Fine.
And our geo footprint across the globe is increasing slowly. So I'll have to see what was the participation today. But last time we had participants from Congo and from Australia.
Oh, great.
So the footprint is.
It's nice to see that RFHA is spreading wings across India and beyond India as well.
Very true, sir. We have regular participation from Middle East, and Congo and Australia was a new addition last time, sir.
Okay. So thank you very much, and thanks to Dr. Shakti as well. Sir, I'll take leave, sir. Thank you.
Okay, bye, actually.
Bye.
Thank you very much, sir. I'll close this session now, sir.